So good afternoon, everybody, and welcome to the annual lecture, which is our most prestigious event in the BNMS calendar over these 3 days. And it's my honour to introduce to you Professor Val Lewington, who's Professor of Clinical and Therapeutic Nuclear Medicine at King's. She, until recently, was also the Programme Director for the MSc in Nuclear Medicine, and has worked very hard with Charlotte Fowler to relocate that, and that, fortunately, is now going to be taken on by Brighton. Val's done a huge amount for the nuclear medicine community over a very long career. She's an expert in therapy, which we all now know is really the future of our specialty. Theranostics is really coming to the fore with lutetium-177 PSMA around the corner. I think therapy is going to have a really new focus, and I'm really interested to see what Val has to say in our annual lecture. So Val, if you would take the floor.
Thank you, Richard. Thank you very much for the generous introduction. And thank you to the BNMS for giving me the huge privilege of giving this year's annual BNMS lecture. It's just fabulous to be at a face-to-face meeting after 2 years of seeing people online. The buzz around here is just fabulous, and it's always a treat to come back to Glasgow. I have family roots in Glasgow, and it's always good to have an opportunity and a good excuse to visit. So the title of my talk is Molecular Radiotherapy, Thinking Aloud. And one of the things I would like to cover is to talk about the evolution of molecular radiotherapy over the years. For those of you who are new to all this, to explain some of the key steps in the development of MRT across the UK. I'd like to think about whether or not we're really exploiting the full potential. What could we do better in MRT in the future? I'd like to touch on some of the challenges that we've overcome in the past, but also flag up some of those that you're likely to face in the future. And then look at education and training to ensure that the future of theranostics and molecular radiotherapy is in safe hands. Now, of course, I've also got a hidden agenda, and my secret agenda is that I hope through this meeting that I can speak to as many of you as possible, that I can entice you, cajole, and encourage you to become tomorrow's leaders for molecular radiotherapy. So take up the baton, no pressure, off we go. So I do have a few disclosures. So, a long time ago, in a far, far away place, in a different millennium actually, I was a first-year registrar in nuclear medicine, and I was working in Southampton. And my boss at the time, Professor Duncan Ackery, said it was about time that I got out and about, and I went to some meetings. And I went to my very first ever medical meeting, which was the BNMS Annual Meeting at Imperial College in London. So I'd never been to a conference before. I didn't know what to do. I didn't know who anyone was. I felt like Billy No Mates, and so I had no option but to go to all of the lectures. And the annual lecture that year was delivered by one of the true forefathers of nuclear medicine. He was a towering figure in the specialty in the United States and internationally, and that was Dr. Henry Wagner Jr. And in his annual lecture, he said, "The future of nuclear medicine lies in therapy and in PET," which was a really bold statement at the time, because as far as PET was concerned, the opening of the first clinical PET centre in the UK was some years off. We're talking about the late 1980s. As far as therapy was concerned, actually it was blissfully simple. We only had 2 therapeutic radionuclides to use. There was radioactive sodium iodide labelled with iodine 131, which was used to treat thyrotoxic little old ladies, the emphasis being on old, and also to treat differentiated thyroid cancer. And the other treatment was radio-labeled sodium phosphate to treat myeloproliferative disease, again, predominantly in an elderly population. And our prescription, our delivery of treatment was very much based empirically on custom and practice. Evidence-based medicine was way down the line. And you could argue, in fact, going slightly at a tangent here, but it was the success of radioactive iodine in curing metastatic thyroid cancer that in some ways suppressed our enthusiasm to systematically review alternative treatment options and drive the specialty forwards. Because to be able to cure an epithelial cancer with minimal toxicity, even in the context of blood-borne or lymphatic metastases, is remarkable. Radioactive iodine is still up there. It is the gold standard against which we should compare all of the other treatments that have subsequently been developed, some of which we'll be touching on today. It was the gold standard, it still is. And there is nothing to compare with it in terms of efficacy and tolerability. But I digress. Right, back to the main theme. So, Dr. Wagner said the future would lie in PET, and he was right, as you know. So we moved in the UK from gamma camera PET with dual coincidence imaging on gamma cameras to, as you've heard, the first clinical PET centre. Then we were able to merge the PET images with cross-sectional imaging, with CT and eventually MRI. There was a whole flood of innovative tracers, of new PET radio labels, and tantalizingly, it seems that whole body PET is probably just within reach and will be within the near future. But back on planet Earth, where I lived at the time, the prospect of being able to become committed to PET if you worked outside London in the late 1980s was incredibly low. But I was so lucky to be training in a department where my boss, Professor Ackery, had a background in radiobiology, and he had a real interest and huge intellectual input into the development of molecular radiotherapy. I think we were probably the first centre in the UK to make and subsequently administer I-131 meta-iodobenzalguanidine for patients with metastatic pheochromocytoma and paraganglioma. The rules were a little bit more flexible then, should we say, than this. Wouldn't really recommend this as a course of action now, but hey. And we went on from there to develop a program using bone-targeted therapies for patients with metastatic bone pain, predominantly in the context of metastatic prostate cancer. So we were using strontium-89 dichloride, samarium-153, and rhenium-186 bisphosphonates. And these were very effective treatments as palliation for patients with multifocal systemic disease. I think it was the emergence of bone-seeking radiopharmaceuticals, which were effective, that was this tiny spark that began to ignite interest in the pharmaceutical industry. And certainly, this became the tipping point to get funding, to get resources, to drive the future of evidence-based medicine through clinical trials. Moving on to the early 2000s, there was radioimmunotherapy. There were two key drugs. There was I-131 tozotumumab, otherwise known as Bexar, and yttrium-90 ipilimumab tioxetan, known as Zevalin. And these were really effective treatments for patients with refractory non-Hodgkin's lymphoma. But they were perceived to be very difficult to administer, and the reason behind that actually was that oncologists and hematologists were very wary of handing over the care of their patients to nuclear medicine physicians whom they didn't know, who they never came across in their day-to-day practice. And this was about the same time as bone marrow transplantation for lymphoma was beginning to become more widely used. And to cut a long story short, the clinicians felt much more comfortable at embracing what they were familiar with rather than using something new. So despite the efficacy of these agents and despite strong patient advocacy, in fact, they never really realized their potential and they gradually fell out of use. But it wasn't all bad news in the early 2000s because this heralded the arrival of peptide receptor radionuclide therapy, PRRT, targeting somatostatin receptors which are overexpressed on the cell surface of neuroendocrine tumors. And there were two international centers that really pioneered this work. In Rotterdam, in the Netherlands, and in Basel, in Switzerland. The use of very high activity indium-111 octreotide pentetratide exploited the therapeutic potential of the Auger electron emissions of indium-111. But to be honest, this was very soon overtaken and superseded by the development of yttrium-90 DOTATOC, yttrium-90 being a high-energy, long beta particle range beta emitter. Now, this was greeted with such enthusiasm by the nuclear medicine community that centres popped up all over the place across Europe. Pretty much, or many nuclear medicine centres started undertaking their own radiolabelling of yttrium-90 DOTATOC and developing their own compassionate use treatment programs. And patients came in from all over the planet to receive treatment in Europe for their neuroendocrine disease. The problem was that there wasn't an industrial sponsor, and so we didn't particularly invest in randomized controlled studies. And although these were very effective treatments, they didn't really gain much traction with the oncology community who wanted to see the clinical trials. The next step was a rather different approach, moving away from systemic to local regional treatment with the arrival of yttrium-90 radio-labeled microspheres, either resin or subsequently glass microspheres, to treat either hepatocellular cancer or organ-confined metastases from colorectal cancer. This was a very different approach. The radio-labeled microspheres are injected by intra-arterial injection directly into the liver blood supply. And so this requires the skills and the input of a very skilled interventional radiologist. What sets this treatment apart from all of the others we're talking about today is that from the outset, the key message was that we needed to focus on individual patient planning and treatment planning with dosimetry. And that has not been adopted for many of the other treatments we're discussing. The approval of the calcium analogue radium-223 dichloride as the first-in-class targeted alpha therapy in 2013 was a huge step forward. Clinical trials, the phase 3 pivotal study, the Alsimca study, showed that radium-223 not only improved symptoms for men with refractory prostate cancer, but it also prolonged survival. And this was a game changer because the pivotal paper was written up by an oncologist, it made it into the New England Journal of Medicine, and suddenly we were on the radar of the oncology community. And the oncology community began to sit up and pay attention to the potential of molecular radiotherapy. From the nuclear medicine perspective, this treatment is remarkably straightforward to administer. It can be given on an outpatient basis. It's fairly undemanding in terms of the radiation protection restrictions that patients have to follow. And once radium-223 had received NICE approval in the UK, several centres began to increase their molecular radiotherapy workload in order to be able to cope with demand. Next came lutetium-177 oxydotrotide. Now, this is a different peptide receptor radionuclide therapy, PRRT, and the key here was the introduction of lutetium-177 as a therapeutic radionuclide. It's a medium energy beta particle emitter, and because of that, it avoids some of the side effects that have been associated with its predecessor, yttrium-90 DOTATOC. A global phase 3 randomized study, the NETA-1 study, showed that patients who received repeated cycles of lutetium-177 oxydotrotide, also called Lutathera, which is easier to say, had prolonged progression-free survival and median overall survival compared with patients who were treated with cold somatostatin analogues. This has had a huge impact on the management of neuroendocrine disease globally. Lutathera very rapidly made it into treatment guidelines. It is now pretty much recommended as second-line treatment after failure of cold somatostatin analog therapy for any patient with progressive, inoperable, grade 1 or 2 neuroendocrine tumor of gastrointestinal or pancreatic origin. Let's come into this decade, we're nearly there, and the arrival of radio-labeled particles Oncosil, labeled with phosphorus 32, and this was launched and approved as a breakthrough medical device for the treatment of locally advanced pancreatic cancer, which is a tumor that we all know has a truly awful prognosis. The Oncosil is administered in combination with systematic chemotherapy by direct injection into a tumor via an endoscopic ultrasound route. So to deliver this treatment, to be honest, the nuclear medicine input is relatively minor by comparison with the input needed from endoscopists and from gastroenterologists, and also from the treating oncologists. And then finally, coming bang up to date, or perhaps anticipating events, there is lutetium-177 PSMA, prostate-specific membrane antigen, for the treatment of men with refractory prostate cancer. Now, this has already been approved in the United States by the FDA, and I'm mentioning it here because I think it's very likely to be approved in the UK and Europe at some point this year. And that approval will be based on the results of the VISION trial, which was a global study examining the efficacy and the tolerability of between 4 and 6 cycles of lutetium PSMA in men with advancing refractory prostate cancer. The study showed that those patients who had received lutetium PSMA had prolonged progression-free survival as assessed by imaging, and also had prolonged median overall survival. Now, this is going to have a huge impact on our practice. Clearly, it's of huge importance for patients and their carers, but prostate cancer is common. It is the most common cause of cancer in men in the UK, or we're approaching 50,000 new cases per annum. So we need to find a way of stepping up to the plate in nuclear medicine to ensure timely access to the men who are going to need this treatment now. 7 centres in the UK gained some experience using PSMA as part of the VISION study, but if we add those centres to the 20 that are currently commissioned to deliver PRRT, we're still going to find that we've got a bit of a shortfall. And we need to think about, part of thinking aloud today is to wonder how we might be able to manage that. Now, in addition to all of these agents, there are a few drugs in development. I'm going to touch on them really quickly. Firstly, there's actinium-225 PSMA, which is being pioneered in Germany and also in South Africa. And you might say, well, if we haven't actually got lutetium PSMA on hand yet, why are we talking about actinium? But There are preliminary but somewhat anecdotal reports, particularly from Germany, suggesting that this is a very effective treatment for, again, for refractory prostate cancer. Next, there are the targeted thorium conjugates, radiolabeled with thorium-227. Now, thorium is a really interesting radionuclide because it is an alpha particle emitter and it decays down to radium. And we know a lot about radium already. If the radiochemical integrity of the decay products of thorium can be harnessed and can be preserved, then potentially thorium-227 is going to be a really potent therapeutic radionuclide. Clinical trials are currently in the planning stage, I think, using conjugates, particularly antibodies targeting hematological malignancies, but also potentially PSMA antibody. Next, there is FAPI, which is fibroblast activating protein inhibitors. And FAPI imaging, for those of you who are interested in PET, is becoming one of the new go-to PET tracers. There are endless papers on gallium-68 labeled FAPI, for both, which has many applications, both for benign and malignant indications. Very preliminary data suggest from Germany, again from the Bad Berka group, suggest that FAPI may be of value in treating patients with poorly differentiated adenocarcinomas. Preliminary data suggest that it appears to be reasonably well tolerated, the biodistribution is reasonable, that tumor retention is prolonged. What sets FAPI apart from the other agents we've discussed is that we're not actually targeting tumor cells. FAPI is targeting the tumor microenvironment and the interactions and signaling between cancer-associated fibroblasts and the microenvironment, the local tumor matrix. So that's why it's important that it's labeled with lutetium-177, which has got a sufficiently long particle range to be able to stretch across the tumor matrix and achieve cell kill. And then finally, we come to NeoB. NeoB stands for gastrin-releasing peptide receptors, or GRPR. And these receptors are overexpressed on a wide range of solid tumors, particularly breast cancer, lung cancer, gastrointestinal stromal tumors, and even glioblastoma. Phase 1 and 2A studies are already underway in the UK, and this is looking as though it's has enormous promise for the treatment of some very unusual and refractory solid tumours in the future. Now, this isn't a comprehensive list. I'm highlighting, what I want to highlight here is not just the breadth of drug development, but the pace of change in the specialty. I think with all of the drugs that are in the pipeline, with those that we can already access, this is a unique opportunity to move molecular radiotherapy and put it right at the forefront of cancer medicine in the future. We talk about the term, we use the term Theranostics when we're talking about combining PET with therapy. For those of you who are purists in the audience, the word Theranostics was originally coined to talk about radiolabeling some tracer with different isotopes of the same element. And the best example of that was iodine. We have iodine 123, 124, 125, 131. And several other theranostic pairs that have been explored over the years are shown here. Nowadays, we're using the term rather more loosely. When we talk about theranostics, we mean the same targeting tracer, but for PET, we're usually labeling with fluorine-18 or with gallium-68, and then we're interchanging that with lutetium-177 as our therapeutic radionuclide. Now, that's fine, provided that the change in element doesn't alter the biodistribution of the radiolabeled drug in vivo. The third step in the evolution of MRT was to move from the status of enthusiastic amateurs into the modern world with development of evidence-based medicine and clinical trials. And the obvious design for us to follow and adopt was that of standard, well understood oncology trials. Because it's a robust method, everybody knows what they're doing, clinicians understand it, it produces results that are credible, not just to oncologists, but also to licensing authorities, to regulators, and to the pharmaceutical industry. But there are some drawbacks with the conventional oncology drug trial design, because conventional design will miss some of the molecular imaging that can be used for patient selection, and particularly for assessing response to treatment. I am not going to waste your time today discussing the limitations of RESIST criteria as a study endpoint to evaluate the effectiveness of molecular radiotherapies. The other oversight with oncology trials is that they give very little more than a passing nod to dosimetry. They'll do just enough to keep the regulators happy, but it sort of stops there. And there is a tendency to prescribe molecular radiotherapy as a sort of radioactive chemotherapy, which is just wrong. It completely misses the point and the potential advantages of a molecular therapeutic approach. And then finally, final comment, is that innovation tends to slow down once a drug has got marketing authorization. There is absolutely no appetite to go back and look under the bonnet and see if we can do some dosimetry retrospectively. There is no financial incentive for sponsors to support that, and sponsors are looking to find new extensions of their existing drug label, not to go back and revisit the original one. So you either do dosimetry at the time, or you just let it go completely. So are we getting the best out of molecular radiotherapy? What could we do to improve the outcomes for treatment? And one option would be to optimize patient selection. There is now good evidence to support correlative imaging in order to select patients appropriately for treatment. One very good example of that is the NET PET score. And this grades the relative uptake of somatostatin analog gallium dotatate and compares that with FDG PET uptake in the same patient. And this then will give a grading system according to the balance of uptake between those two tracers. And so what you're looking for is something like the patient shown here, who expresses somatostatin receptors but doesn't have any FDG uptake. This is a low NET PET score, and we can predict that this patient will do very well with lutetium PRRT, compared with the patient at the opposite end of the spectrum, who is very much less likely to benefit. The NET PET score has been shown to be superior at predicting outcome to conventional WHO grading systems for neuroendocrine tumors. Another example here of patients being considered for lutetium PSMA treatment. So on your left, we have paired gallium PSMA PET images and FDG in a patient with very low volume metastatic prostate cancer. And you can see very intense PSMA avidity in low volume skeletal metastases with no correlation on the corresponding FDG PET scan. But on the right, we have a patient with much more advanced disease. And we know that with successive cycles of treatment, the tendency is for the tumor to become much less well differentiated and to take up much more FDG. And if you compare these two images, you'll see there are some sites where there is discordant uptake of FDG and PSMA. There are some sites where FDG uptake is significantly higher. So this patient isn't going to benefit from lutetium PSMA therapy because we simply won't be able to deliver a sufficiently high absorbed radiation dose to those sites that don't concentrate PSMA well. But in the meantime, those sites will progress effectively untreated because they have a more aggressive tumor type. phenotype. Could artificial intelligence help? So there are several talks during the conference this week on radiomics that are going to be better informed, more articulate, much more eloquent than me. And I suggest you go to some of them. But anyway, radiomics describes a standardized method based on mathematical models to identify tissue, and specifically, in this context, tumor heterogeneity, and to identify prognostic features that can be quantified and used as predictors and prognostic markers. This is really gaining ground very quickly with respect to CT, with MRI, and increasingly with PET. It hasn't quite become mainstream, but it's not very far off. But it's very reasonable to say that molecular radiotherapy has arrived a bit late on the scene. There are a couple of papers that I could find that described the application of radiomics to select patients for molecular radiotherapy. This is one example in which the baseline gallium PSMA study was used to predict outcome to lutetium PSMA treatment. And to cut a long story short, it was shown that tumors that had more heterogeneous patterns of PSMA uptake tended to respond rather better to lutetium PSMA. So this was a favorable prognostic indicator. The group at UCL in London have embarked on some very detailed research looking at the role of radiomics to predict outcome to PRRT using lutetium oxydotrotide. They've identified some specific radiomic features, skewness and entropy, which seem to correlate with outcome. In particular, low skewness and high entropy is associated with a poor survival, with a short progression-free survival, and with a poor outcome. Now, these data are based on relatively small numbers of patients, and the authors conclude very reasonably that to optimize patient selection, it would be sensible to combine the radiomic signature with evidence of texture heterogeneity, and then to add that to clinical parameters in order to select patients best for treatment. Lastly, there's pharmacogenomics. So this is where we look at an individual's genetic makeup and the impact of that upon their response to different drugs. Now, this is a very new approach as far as molecular radiotherapy is concerned, but it's a very logical one because we know that the genetic fingerprint of individual lesions will change in response to repeated and different cycles of treatment. So the more lines of treatment a patient has received, the more likely they are to have a very heterogeneous genetic pattern of genotype in the metastatic lesions. And this is where molecular radiotherapy sits. It's usually some way down the line rather than at the beginning of the patient's journey. But it's been shown that loss of DNA damage recognition and signaling genes can contribute to radioresistance. Conversely, that some germline mutations may actually increase radiosensitivity. And there's a really intriguing insight into this that has come from the Heidelberg group, who are really probably the global leaders with radioligand research, particularly in prostate cancer. And they observed that in their expert hands, around 30% of patients just didn't respond to actinium-225 PSMA treatment, and they just didn't understand why. On the basis of diagnostic imaging of PSMA avidity, these patients should have done really well, but the treatment just didn't work. So they went back to look at the genetic profiles of non-responders, and they were able to show a significantly increased frequency of DNA repair and checkpoint gene mutations in 86% of the men who had failed actinium PSMA therapy. Across the pond at Johns Hopkins, a group has shown that patients with metastatic prostate cancer who had either inherited or acquired homologous DNA repair gene mutations tended to respond better in terms of biochemical response to radium-223 dichloride. So where does this leave us? We're not at a stage where we can apply this knowledge, but interest in genomics is expanding and growing very quickly. And it's not uncommon for many patients now to undergo what's called next generation or sequencing, meaning genetic profiling, to assess their suitability for some of the other drugs on the market. This is particularly the case in prostate cancer. So might we be able to exploit that information in order to select patients better for molecular radiotherapy, either as a monotherapy or actually maybe to signpost the direction of travel for considering combination therapies, linking molecular radiotherapy to other treatments and giving them simultaneously. Now let's move away from patient selection, and the time has come, I'm afraid, to address the elephant in the room, which is personalized dosimetry. So, deep breaths. It is often quoted, maybe erroneously, and attributed to Albert Einstein, but it's never a bad idea to drop the name Einstein when you're doing a presentation, that insanity is doing the same thing over and over again and expecting different results. But you could turn that on its head and say that insanity is doing things differently over and over again and expecting to get the same results, because that's where we are with MRT. These 4 patients were all referred for consideration of PRRT with lutetium oxydoxyritide. They're all somatostatin receptor positive, but even a cursory glance will highlight the significant differences both in the burden of disease and the distribution of metastases between these 4 patients. So on your far left, you've got very low volume soft tissue disease, a tiny little dot in the lung and then dots in the liver. The next patient has got a really big bulky tumour in the inferior part of the liver and early bone metastases. Patient number 3 has got multiple, almost conglomerate hepatic metastases with not much elsewhere. And the patient on your right has got disseminated diffuse skeletal metastases combined with bulky conglomerate hepatic metastases. But the marketing authorization and the approval for lutetium PRRT says we treat them all the same. They're all eligible to receive 4 cycles of 7.4 gigabecquerels of lutetium-177 oxydoxyritide. This makes no sense. But to be fair, the marketing authorities are basing their decisions on a one-size-fits-all premise, because that was the premise that underpinned the NETA-1 study. We took on all comers, irrespective of their tumour burden. All comers received 4 cycles of PRRT, and it worked. This is evidence-based. It was effective, it was tolerable, above all, it was doable. But was it actually optimized? Surely we could do better than this, perhaps with the help of personalized dosimetry. So the difficulty we face, or one of the many difficulties we face, is that we understand far less about dosimetry from unsealed source therapy, internal dosimetry, than we do about external beam radiotherapy. With external beam treatment planning, we're usually talking about a single tumour mass. We know what our intended or target radiation absorbed dose is to achieve a tumoricidal effect and achieve cell kill. We also know what the tolerance of surrounding tissues are so that we can mitigate that by adjusting our treatment plan. But we can't just uplift, cut and paste our understanding of external beam dosimetry and assume that it applies to unsealed source therapy, to molecular radiotherapy, because we're very often talking about multiple sites in systemic disease. What's our target? Is the target in this particular patient these 2 bone metastases? Or actually, are we more worried about trying to constrain the dose-limiting effects to normal tissues like the kidney or the salivary glands? even if we decide that we know what our main target is and we're going to plan around that, for example, this patient with a neuroendocrine tumour, do we actually know what the intended absorbed dose is in grey? And is it the same for a neuroendocrine tumour as it is for thyroid cancer or for prostate cancer? We actually don't know what the intended dose is that we're trying to deliver. And then we go on to look at metastatic disease. So does the absorbed dose, does our dose prescription need to reflect differences according to the tumour site? Does it matter whether the disease is in the liver or in the bone or the lung or the lymph nodes? We don't know any of that yet. We don't know anything about fractionation or about the optimal interval between different cycles of treatment. What we do know is that what we are doing now seems to work some of the time, and so that's why we do it. Surely we could do this a bit better. But if this is beginning to make your brain ache, this is as nothing compared with the actual barriers to making personalised dosimetry mainstream and routine in clinical practice. Because the prerequisites for undertaking dosimetry are that we would need a nationalised standard for molecular imaging. That means going around and calibrating all the scanners and all of the cameras across the country so that we were sure that we could compare results between centres and build up an evidence base. And if you're going to set up a standardised system, then you're going to have a quality assurance programme in place. And you're going to have to analyse your data according to agreed software. Now, luckily, there is a very good template for us to follow, and this was the setting up of the UK's PET core lab for pretty much the same reasons, in order that data collected from multiple sites that were contributing to multi-centre trials in lymphoma could be collated and were quality assured. So we've got a roadmap to follow, a very successful roadmap. We don't need to reinvent the wheel, but we've got capacity issues. You all know how busy you are at the moment in terms of camera capacity, just trying to catch up with the backlog from COVID. We also have a significant workforce shortage for specialist dosimetry physicists, but also specialist technologists. I'm going to touch on workforce again in a minute. And if that wasn't enough, patients really don't like coming back to hospital again and again for diagnostic scans. There may be a solution to that, and if you're interested, it might be worth attending one of the presentations tomorrow morning about single time point dosimetry. I think we need to find solutions. It is no longer good enough just to say dosimetry belongs on the too hard pile, and I'll come back to it some other time. But the solutions that we need for clinical practice and for research are very different. For clinical practice, realistically, it's going to take a huge investment to reconfigure and expand services that can deliver routine dosimetry on a personalised basis. And pragmatically, we just can't wait to do that. Pragmatically, we are stuck with prescribing molecular radiotherapy for the medium term according to fixed activities. But it's different for research. For research, we absolutely need to embed quantitative imaging and dosimetry in clinical trials. Not least so that we can build up the expertise and a clinical trial network, as we saw with the core net labs. That will help us to develop the evidence base to support and underpin dosimetry expansion, and above all, to demonstrate that all this hard work, all this effort, all these resources are worthwhile, and that undertaking personalised dosimetry improves outcomes. Now, we touched on workforce very briefly. There is a huge range of different models of care for delivering molecular radiotherapy across the UK. At one far end of the spectrum, there are services that are nuclear medicine-led, where we run our own clinics, we organise our own imaging, we deliver the treatment, we give inpatient care, we follow patients up ourselves. It's hugely rewarding, but it's really labour-intensive. I need to express a bias because that was the system that I was brought up with. At the other end of the spectrum are services that are perhaps led by oncology or sometimes endocrinology, where it's the oncologists who run the clinic, who prescribe the treatment, who undertake the follow-up of the patients. And the commitment of nuclear medicine services here is much less onerous, and the focus is very much on delivering the treatment and ensuring the safety and radiation protection regulations are in place. Now, if you go to different centres across the UK, there will be endless different permutations of this particular model, developed over custom and practice according to local priorities. But what brings everything together is the multidisciplinary team and the multidisciplinary team meeting. From the imaging perspective, imaging in multidisciplinary cancer meetings is going to be obviously interpreted by radiologists. If you're lucky, it may be a radionuclide radiologist. It's very unlikely to be a nuclear medicine specialist because there just aren't enough of us to go around. And the role of the reporting radiologist within that MDT is to interpret and guide appropriate imaging, but to be a knowledgeable advocate for molecular radiotherapy. When it comes to thinking about therapy in the MDT, the usual decision maker is the oncologist. Occasionally, maybe a radionuclide radiologist, very rarely the nuclear medicine specialist. It doesn't really matter who does it, provided that they are a true evangelist for molecular radiotherapy, that they know their stuff, that they hold their ground, that they will argue the case for molecular radiotherapy because they understand the disease process and they understand the pros and cons of all of the other treatment options that might also be discussed. One of the main reasons why access to molecular radiotherapy is so patchy across the UK is because of the knowledge gaps that exist in MDTs. And it behoves us all to stand up and be counted. And I'm telling you, from personal experience, it can be really uncomfortable to stand up as a nuclear medicine specialist in a cancer MDT and argue the toss with the oncologist for molecular radiotherapy. But it's time to do that. A quick jolt of reality. So I don't think we know the number of clinicians who have MRT responsibility in the UK. RSAC knows the number of licence holders, but not the details of their practice or how much molecular radiotherapy they do. So whilst there are many specialties who can do molecular radiotherapy, I have a bad feeling that it's actually an inverted triangle. The number of true MRT specialists is actually very low indeed. So we need to do something about that. We need to train more specialists so that we can meet the potential of all the drugs that I've shown you that are coming along in the pipeline. So that takes us on to training and the clinical workforce. So the training program for nuclear medicine physicians has evolved over the past decade. It's very much skewed towards hybrid imaging because that's where most of their work is going to be. The curriculum specifies that they must have theoretical training in molecular radiotherapy, but that can get a bit lost amidst the pressure of getting to grips with hybrid imaging. Fortunately, there is a new molecular radiotherapy module within the diploma that is just being established at Brighton and Sussex Medical School, which is going to be launched later on this year, replacing the MSc that used to be run at King's in London. This module will be compulsory for nuclear medicine specialists and nuclear medicine physicians, and again will reinforce and underpin that theoretical knowledge. Radionuclide radiologists, well, to be honest, they're going to focus on, or you are going to focus on hybrid imaging predominantly, but you will be able to access that diploma. Clinical oncologists, yes, their curriculum includes a small section on isotope therapy, but it's one of 19 core areas of knowledge that they need to get under their belts before they get their CCT. So it's easy again to see how isotope therapy or molecular radiotherapy could get lost in the general noise. But again, they will be eligible to pick up theoretical knowledge from the new diploma programme. So essentially, we have three types of specialists who could deliver molecular radiotherapy. There's a nuclear medicine physician. Now, the disadvantage for us is that there aren't enough of us to go around. We're a very rare breed. And that having focused so much on hybrid imaging during the training program, many nuclear medicine trainees will feel that they have perhaps lost some of their clinical skills. They will certainly have lost clinical confidence in managing patients by themselves by the end of their training program. Loss of clinical acumen probably almost certainly applies to radionuclide radiologists as well. And they're also incredibly busy. They're trying to sort out their MR and their CT lists, their waiting list initiatives, etc. So then there are the clinical oncologists. Now, their strength is their clinical skills, which obviously is key to their role in oncology. But it's very unlikely that a clinical oncologist would have a significant job plan commitment to molecular radiotherapy because of all the other competing priorities. It's going to be shoehorned in around their major tumour areas of interest. So that takes us to the second elephant in the room, which is, to whom are we going to entrust the future of expanding molecular radiotherapy in the UK? Who's going to lead in individual centres? Honestly, I think we need to focus far less on the individual background of the specialists involved and to concentrate far more and to value the skills that they bring, provided that people have been appropriately trained, that they have the skill set, that they're enthusiastic, that they will work collaboratively, that they want to do it and they're good at doing it and they keep their skills up to speed. I don't think it matters who leads the molecular radiotherapy service, provided that it's done well. So we've talked about the clinical workforce. The workforce issues apply across the piece to all of the professionals, all of you involved in delivering molecular radiotherapy, the physicists, radiopharmacists, technologists, radiographers, nurse specialists. You all have your training programs in place. Would it be feasible to just sneak in a little mini module on molecular radiotherapy within existing training programs? Possibly. So you could develop a subspecialty interest. That theoretical knowledge would need to be bolstered by a mentoring, by work placements in busy centres so that you could gain some practical skills. And all of that would obviously need to be funded, so maybe some fellowships or bursaries. But if we're really thinking aloud and we're thinking without borders, then maybe it really is time to establish an academy for molecular radiotherapy, education, training, and research in the UK. Now, I'm just leaving you to dwell on that for a second. It's important to see this in context. Healthcare professionals are not the only people who are interested in molecular radiotherapy and in its future. I had no idea, frankly, of the sums involved that are being invested by industry in radiopharmaceuticals generally, but with a particular emphasis on theranostics. These are eye-watering amounts of money, specifically focusing on the radiopharmaceutical market. The number of clinical trials that are now using radiotracers that are logged in the UK is growing very rapidly, greater than a twofold increase over the past decade. But to me, I think it is very encouraging to realize that wily businessmen, venture capitalists, investment bankers really recognize the potential of molecular therapy and theranostics in the future to the extent that they're prepared to back it financially. The trajectory of the increase in funding over the past decade has been astonishing and is likely to continue. What that says to me is that they think the future for molecular radiotherapy is bright, that it has enormous potential. And it's very interesting to see that and appreciate that from a very different perspective from our own. So finally, to quote Rod Hicks, who said it so beautifully, that the difference between medicine and magic is that magicians know what they're doing. So, if you want to be an MRT magician, you are building on a very strong scientific platform. The way ahead for you is clear, I think. You're going to need to develop an MRT framework and expand that framework urgently in the UK. And above all, you're going to need not just to strengthen cross-specialty collaboration, you're going to need to seek out collaboration on an equal footing with and welcome input from specialties other than nuclear medicine itself. Very much on an equal playing field. So finally, I would like to thank Henry Wagner for his inspirational lecture, to my original mentor, who was astonishingly patient, Professor Ackery, and to all the people who've helped along the way. To misquote Robert Frost, nuclear medicine really is the road less travelled as a career path. But that makes all the difference. Whatever you do, don't let this opportunity pass you by. The potential for molecular radiotherapy in the UK is huge. Take the baton, run with it, and lead from the front. Thank you.
So Val, thank you for that inspirational call to arms in molecular radiotherapy. Open the floor to questions. Are there any questions? While people are thinking, I've got a question. So talking about lutetium-177 PSMA, the index scans for selecting the patients for whether they're appropriate for treatment or not, can we use those for crude dosimetry?
Potentially, yes, but I think because it's so new and because so few centres have had any experience in using it, it's going to be, we're some way behind the curve. It's going to be a big learning curve to understand how to do that. But perhaps, I think, going back to both, there's dosimetry, but there's also the radiomics. And that may be very useful in selecting patients for treatment and predicting outcome.
Okay. I've got another question. You talk about a molecular therapy sort of national academy model. That's something that's been done in breast radiology by HEE and also in CT colonography as well. So I think there are models on which, you know, it could be based. Have you had any discussions with HEE?
No, I haven't. I thought I'd come up with this as a blue sky idea, and then I started a meeting on Sunday when several other people were thinking exactly along the same lines. So no, we haven't, but I agree with you completely. There are good models out there. And I really think the time has come to put molecular radiotherapy on the map, and this would be a very sensible way of doing it. And it would be open to all of the professions, not just the medics, but to all of the professions who are contributing to getting a service, delivering a service for the future.
Yeah, and that's exactly how the breast model works. It's multi-professional. Okay, I think it's probably difficult to ask questions with such a large audience. So what I'm going to do is present you with...
Thank you.
Brilliant.
Thank you very much indeed.
Thank you.
Go for that. Thank you. Thanks, Richard.